We have a 62-year-old man with a past medical history of alcoholic liver disease, COPD, chronic kidney disease stage 3, severe osteoarthritis, and a hiatal hernia, who's presenting to the with 4 episodes of hematemesis. His home medications include furosemide, spironolactone, an albuterol inhaler, and ibuprofen. 3 days ago, he was diagnosed with acute bronchitis when he presented with persistent coughing and wheezing and got prescribed levofloxacin. His symptoms are only mildly improved since then. This morning, he had a large breakfast with a few items that were quite spicy and caused him to have significant heartburn. A little while later, he was startled to see bright red blood in his vomitus. Shortly afterward, this was succeeded by 3 more episodes of vomiting with bright red blood. He currently feels lightheaded and dizzy. He feels his heart beating fast, and he has mild tremors and shaking. These are his vital signs and his height, weight, and BMI. His blood pressure is low, 98/53. Heart rate is fast, 123 beats per minute. He's tachypnic. He's hypoxic. These are his labs. Hemoglobin is low, 7.8. Platelet count is low, 88,000. Sodium and potassium are low. Creatinine is elevated, and he's hypoalbuminemic. Normal albumin is 4, so this is low. Okay, here's the image. You consult gastroenterology. The gastroenterologist takes the patient for an emergent endoscopy. During the endoscopy, they see this. Here's the question. Which item in the history of this patient is most strongly associated with this clinical presentation? Thrombocytopenia, coughing, chronic kidney disease stage 3, ingestion of spicy food, or NSAID use. Okay, so again, it's good. It looks like we have a spread. So there's all answers. Somebody has been choosing them. The most popular answer is NSAID use. And the second close and most popular is coughing. So let's see what the correct answer is. And the correct answer is coughing. So what exactly is this? So this is a Mallory Weiss tear in the esophagus. So if you see this image, as you can see, all this part is the esophagus. Where you see the black, that's where the stomach is. So this area here where my cursor is right now is the esophagogastric junction. And this is a huge tear in the esophagus with fresh blood oozing out. Now remember that I told you this patient was recently diagnosed with bronchitis and has been coughing. So anything that increases intra-abdominal pressure can lead to esophageal tears, such as this tear. So this is what it is. It's a Mallory Weiss tear. So this is a Mallory Weiss tear. His coughing is the most strongly associated risk factor, which was the second most chosen answer. For Mallory Weiss tear, vomiting, lifting or straining, coughing, seizures, acute abdominal injuries, insertion of a nasogastric tube, and gastroscopy are usual precipitating events. The pathophysiology is likely related to increased intra-abdominal pressure. He's an alcoholic who most commonly have increased portal pressures to begin with. Further increase in vascular pressures due to increased intra-abdominal pressure can cause the esophageal mucosa to tear up. The image shows a fresh mucosal tear with bright red blood oozing out. You remember that the patient was thrombocytopenic because he's got underlying alcoholic liver disease. So thrombocytopenia is playing a role because it's making it easy for the patient to bleed, but it's not the most strongly associated risk factor. Again, he's got chronic kidney disease. These people can have qualitative defects with decreased platelet adhesion, which can be a contributing factor, but again, not the strongest one. Ingestion of spicy food can cause some dyspepsia and heartburn, but usually does not lead to an esophageal mucosal tear. And NSAIDs, which was the most popular answer, remember NSAIDs can cause gastric erosions and ulcers, but they are not commonly associated with esophageal mucosal tears. So since this patient has an esophageal tear, NSAIDs would be a less likely possibility.